So what was the impact of COVID-19 on acute myocardial infarction and more generally acute coronary syndromes? And I have no conflict of interest to disclose for this presentation. In fact, this issue asks ourselves many questions. Did the incidence actually decrease? To which extent? What are the causes? In which countries? Etc. Let's start with the first one. Did the incidence of acute coronary syndromes, ACS, change during the pandemic? And you all know that we observed a decrease in this incidence. Nevertheless, at the beginning, one may have expected the opposite, because history taught us that in case of many catastrophes, social fears, some terrific events occurring in the society, the rate of acute coronary syndromes and the rate of death due to cardiovascular diseases may increase. It was the case and very well demonstrated by many studies after September 9/11 in the US. It's the case also in this old study where the incidence of death due to cardiovascular disease after the Los Angeles earthquake in 1994 increased dramatically. So one may have observed the opposite. We also know that SARS-CoV-2 promotes arterial thrombosis, and this may have increased the incidence of acute coronary syndromes. However, and as you know, it was not the case. I think this is the first study that actually showed this strong reduction in Spain. The activity of interventional cardiology investigated in many centers decreased dramatically. The number of percutaneous interventions decreased by not less than 50%. This was also very clear in this survey of the European Society of Cardiology. They asked cardiologists and cardiovascular nurses over the world whether they had the feeling that the number of interventions had actually decreased. And you see that the large majority of colleagues said that the number of patients presenting with STEMI had decreased dramatically, and that you see that it was the case all over the world. Actually, it is impossible to count the number of studies that have been published to show during the first wave that the incidence of acute coronary syndrome, STEMI, non-STEMI, had decreased in their country. It was done, I think, in almost all the countries over the world. In Switzerland, in New York, Indonesia, Veneto region, Sweden, etc., etc. I think cardiologists had no patient anymore, and that's why likely they performed all these studies always with the same methodology, comparing the period during the first wave and a historical cohort or the period just before. Many studies. And I show that to insist on the message that it is definitely clear the incidence was actually decreased. Interesting here, during the first wave, as you see here in this British study comparing with the previous database, you see that the incidence of acute coronary syndromes actually decreased during the first wave, but then it rapidly increased, but without reaching its previous value before months or weeks. In the same study, you see that it was observed for STEMI as for non-STEMI, and this was accompanied by a strong reduction in the interventions for ACS. Primary PCR after 1 day, incidence of and occurrence of CABG, etc. So definitely, it is clear that the incidence of acute coronary syndromes and the interventions for treating such syndromes definitely decreased. Okay, but to which extent did that decrease? It's quite difficult to answer without a meta-analysis. I told you that there were so many studies. For instance, in this meta-analysis, almost 20,000 patients during the pandemic the first wave, it means, and almost 70,000 patients before the pandemic, you see that the reduction on the incidence of STEMI decreased by 72%. 72%. At least one must consider that it was a very strong reduction. What did explain such a decrease? Obviously, there was the fear of infection, of going out, of going to hospital, the reluctance to seek for medical care, and to overload emergency departments. Perhaps also some financial concerns for people who lost their job, or in countries with no or poor medical care insurance. The jammed phone lines and of emergency systems and the lack of ambulances in some countries may have played a role. Perhaps also the fact that in some cases acute coronary syndromes may have been difficult to differentiate from chest symptoms due to SARS-CoV-2. Also, the reduced air pollution and perhaps the decrease in physical activity, both of course due to lockdowns, may have decreased the admissions for ACS. Eventually, all this led to a decrease in admissions for acute coronary syndromes at the hospital. This study is interesting also. They show that the searches on Google for chest pain increased tremendously after the onset of the epidemic of the first wave. Of course, this may come from people with chest pain related to COVID-19, but also perhaps from people with true acute coronary syndromes who did not go to hospital, but who wanted to make a diagnosis by themselves, perhaps. At least it's interesting. Interestingly, this study showed that it was not the same in all the countries. It's the European survey I showed before. You see that in fact, the decrease in the incidence was the largest for countries where there was a full lockdown, in countries with the highest rate of COVID-19 admissions to hospital, and in countries where the cardiology units had been restricted to welcome COVID-19 patients, which is not surprising, but which shows that it might have been in fact different from one country to another, which is a bit obvious, of course. Then, was the prognosis different? And this is, of course, a very important question. Logically, yes, because they delay the reluctance to people to come to hospital. They reduced the care capacity. They delay in presentation of these people and in treatment of these people have led to late presentations, a decrease in the reperfusion efficacy, and so an increase in AMI complications. The paradigm that time is muscle was still true during the pandemic, of course. Look, here in this Israeli study, the time from symptoms to reperfusion was increased by a factor of 5. Also, in this, if we go into more details, in this study still in Israel, you see that the severity of these patients, and it is linked to the delay of presentation, was actually greater. There were less patients in the KILIP 1 class, the less severe, while patients in classes 2, 3, and 4 were more numerous during COVID-19 outbreak. In Italy, during the first wave of the outbreak, admissions for ACS were reduced by 50%, and you see that the case fatality rate increased by 3 times. And it is my message, the prognosis was definitely worse during the pandemic. In this British registry, where patients were compared to a historical registry, I don't enter into details, you see that the delays from symptoms to admission, from door to balloon, and for the overall delay between symptoms and admission were dramatically increased. And as a consequence, the incidence of cardiogenic shock increased a lot. Have you seen it's in STEMI here by more than a double? And not surprisingly, hospitality increased by almost 4 times. It was increased. The results of this meta-analysis are interesting. It was likely not the case in all the countries, as we said before. For instance, the door-to-balloon time increased, but more in Eastern countries, perhaps with countries with a lower income than in Western countries. And you see the list of these countries. So likely it was not the case the same everywhere, and mortality followed that same trend. It was actually significant in Eastern countries and not in Western ones. Of course, since we speak about SARS-CoV-2 infection, we must ask ourselves, were the complications due to treatment actually different? And we know that patients infected by SARS-CoV-2 are predisposed to thrombosins in the veins, but also in the arteries. Was it also the case for coronary arteries? You see that the incidence of in-hospital thrombosis after procedure was much higher in patients with acute coronary syndromes than in patients with AMI and no COVID-19. This was associated with an increase in hospital mortality, and it was higher in case of stent thrombosis, which is of course not surprising. Okay, did we learn from the first wave? Because I told you that most, if not all, the studies I showed you were performed during the first wave. And it's interesting to see here that actually the delay between ECG and activation time was very increased during the first wave, confirming all the other studies, but it was not the case during the second wave. So definitely we lack some data after this first one. So to conclude, yes, the admissions for acute coronary syndromes clearly decreased, at least during the first wave. It was the case in all countries, though it may have depended on local characteristics as the duration and the strength of lockdowns. There are multiple causes, but likely the reluctance to come to hospital and the decrease in hospital capacity are one of the main ones. And definitely the prognosis of ACS was worse during the pandemic. The delay because of revascularization and the rate of complications were actually increased during the first wave of the pandemic. It seems that the infection by SARS-CoV-2 was responsible for more intrastent thrombosis, though it's not that clear and we likely need some more studies. And importantly, the phenomenon was mainly observed during the first wave, and data on later ones are for the moment lacking, but I'm sure that some studies will be published on this topic later. Thank you very much for your attention.